Chronic periodontitis. The periodontal disease comprises of a group of inflammatory conditions of the supporting tissues of the teeth that are caused by bacteria. The American Academy of Periodontology in 1999 classified periodontal disease as gingival diseases, chronic periodontitis, aggressive periodontitis, periodontitis as a manifestation of systemic diseases, necrotizing periodontal diseases, abscesses of the periodontium, periodontitis associated with endodontic lesions, and developmental or acquired deformities and conditions, out of which we will be dealing with chronic periodontitis in today's class. The chronic periodontitis, which was formerly known as adult periodontitis or chronic adult periodontitis, is the most prevalent form of periodontitis. It is generally considered to be a slow progressing disease. Although chronic periodontitis is most frequently observed in adults, it can occur in children and adolescents in response to chronic plaque and calculus accumulation. By definition, chronic periodontitis is an infectious disease resulting in inflammation within supporting tissues of teeth, progressive attachment loss, and bone loss. The major clinical and etiology characteristics of the diseases are microbial plaque formation, periodontal inflammation, and loss of attachment and loss of alveolar bone. So these major shows the amount of calculus present in the teeth, the gingival inflammation, and the loss of attachment. Coming to the prevalence of chronic periodontitis, it affects both males and females equally, and the disease increases with age, and it is an age-associated disease and not an age-related disease. So this means it is not the age of the individual that causes the increase in disease prevalence, but rather the length of time that the periodontal tissues are challenged by chronic plaque accumulation. So it is an age-associated disease and not an age-related disease. Coming to the clinical features, chronic periodontitis is most prevalent in adults, but it can also occur in children and adolescents. Frequently, it will be the supragingival and subgingival plaque accumulation will be there, and also it will be frequently associated with calculus. There will be gingival inflammation, periodontal pocket formation, loss of periodontal attachment, and occasional suppuration. Also, this patient will be having a poor oral hygiene, and gingiva will be typically swollen. The color of the gingiva may be from pale red to magenta. The consistency will be soft or firm. Either it can be soft or firm in consistency. The surface topography, there will be loss of stippling and there will be a smooth and shiny surface. The marginal gingiva will be rolled out and flattened or cratered interdental papilla. There will be increased tooth mobility. There will be furcation involvement, spontaneous gingival bleeding, and there will be variable pocket depths. Both suprabony and infrabony pockets will be there. Coming to the symptoms of chronic periodontitis, the patient may complain of bleeding gums during brushing or eating. There will be increased spacing between the teeth as a result of tooth movement, loose teeth. The condition is usually painless, but sometimes localized dull pain will be there, radiating deep into the jaw. Usually, there will be sensitivity to heat, cold, or both due to exposed roots. The patient also complains about food impaction, halitosis, and gingival tenderness or itching. The types are, it is the chronic periodontitis, the disease distribution, it's considered to be a site-specific disease. The inflammation, periodontal pockets, attachment loss, and bond loss are due to direct site-specific effects of subgingival plaque accumulation. As a result of this local effect, attachment loss and periodontal pockets may occur. It may occur on one surface of the teeth, while the other surface can remain normal. In addition to being site-specific, chronic periodontitis may also be described as localized or generalized. The periodontitis is considered localized when less than 30% of the sites assessed in oral cavity demonstrate an attachment loss and bone loss, while the chronic periodontitis is considered as generalized when more than 30% of the sites assessed demonstrate attachment loss and bone loss. And the pattern of bone loss in chronic periodontitis can be either a vertical, horizontal, or both. So this is a picture showing a localized periodontitis, that is less than 30% of the sites are involved. While in this case, this is a generalized case of chronic periodontitis when there is 30%, more than 30% of the sites shows attachment loss and bone loss. So this is an OPG showing the localized chronic periodontitis in which less than 30% of the sites shows a bone loss, while this is a OPG showing generalized chronic periodontitis in which shows more than 30% of the sites shows bone loss. Both horizontal and vertical bone loss are seen. Coming to the severity of the disease, based on the amount of attachment loss, it is classified into mild periodontitis, moderate periodontitis, and severe periodontitis. So mild periodontitis is about when it is 1 to 2 millimeter of attachment loss is seen. If it is 3 to 4 millimeter of attachment loss, then it is moderate periodontitis, and more than 5 millimeter attachment loss causes severe periodontitis. Coming to the disease progression, the rate of disease progression is usually slow, but it can be modified by systemic or environmental and behavioral factors. Chronic periodontitis does not progress at an equal rate in all affected sites throughout the mouth. There will be more rapidly progressive lesions occurring in interproximal areas of greater plaque accumulation, and in those areas which are inaccessible to plaque control measures such as furcation areas, overhanging margins, sides of malpose teeth, or areas of food impaction. There are several models that have been described or proposed to describe the rate of disease progression, out of which the continuous model suggests that the disease progression, the chronic periodontitis, the disease progression is slow and continuous, with affected sites showing a constantly progressive rate of destruction throughout the duration of disease. The second model is a random model or episodic burst model, which proposes that periodontal disease progresses by short bursts of destruction, followed by a period of no destruction. And the third is the asynchronous or multiple burst model of disease progression, suggests that periodontal destruction occurs around affected teeth during a defined period of life, and these bursts of activity are interspersed with period of inactivity or a period of remission. Coming to the clinical diagnosis of chronic periodontitis, the chronic periodontitis can be clinically diagnosed by detection of chronic inflammatory changes in the marginal gingiva, by the presence of periodontal pockets and the loss of attachment, and also by seeing the radiographs. The radiographic feature shows widening of periodontal ligament space, a loss of corticated interdental crestal margin, localized or generalized loss of alveolar supporting bone, blunting of the alveolar crest due to the beginning of bone resorption. The pattern of bone loss may be vertical or horizontal. The vertical bone loss are usually associated with an intra-bony pocket formation, while horizontal bone loss is associated with a supra-bony pocket formation. Coming to the risk factors of chronic periodontitis. So the risk factor is a characteristic, an aspect of behavior or an environmental exposure that is associated with destructive periodontitis. These are the common risk factors of chronic periodontitis. They are prior history of periodontitis, local factors, systemic factors, environmental and behavioral factors, and genetic factors. The prior history of periodontitis is not a true risk factor, but it is a risk predictor. That is, a prior history of periodontitis puts patients at greater risk for developing future attachment loss and bone loss if given a challenge from bacterial plaque accumulation. That is, the patients present with persistent gingivitis or periodontitis with pocketing, attachment loss, or bone loss may continue to lose periodontal support if not successfully treated. The local factors include plaque and plaque retentive factors. The plaque attached to the tooth and gingival surfaces of the dentogingival junction is considered to be the primary etiologic factor in chronic periodontitis. Also, Porphyromonas gingivalis, Tannerella fossitia, and Treponema denticola, which is commonly called as red complex microorganisms, are frequently associated with chronic periodontitis. And those plaque retentive factors, that is, those factors which facilitate plaque accumulation or prevent the removal of plaque by routine oral hygiene procedures, also contribute to the development of chronic periodontitis. And these factors will allow plaque microorganisms to be in close proximity to the periodontal tissue. Some of these factors include calculus, subgingival or overhanging margins of restoration, deep carious lesions that extend subgingivally, crowded or malaligned teeth, and root surface irregularities. So these are the plaque retentive factors like calculus, some of the plaque retentive factors, which are the calculus, the overhanging restorations, and also the microorganisms. Coming to the next risk factor, which are the systemic factors, which includes diabetes mellitus, those conditions associated with the compromised immune response, nutritional defects, osteoporosis, etc. So diabetes mellitus, it is a systemic condition that can increase the severity and extent of periodontal disease in an affected patient. The type 2 diabetes or non-insulin dependent diabetes mellitus is the most prevalent form of diabetes, and this accounts for about 90% of the diabetic patients. The synergistic effect of the plaque accumulation and modulation of an effective host response through periodontal destruction may be difficult to manage with standard clinical techniques without controlling the systemic condition. So the diabetes will cause chronic periodontitis by altering the microbial flora, by causing a defective neutrophils, and by altering the collagen metabolism. And HIV, which is an immunocompromised condition. So the AIDS epidemics in US suggest HIV positive patients, especially those with AIDS and with low count of T lymphocytes, that is CD4 count less than 200 cells, were at increased risk of chronic periodontitis. Coming to the nutritional deficiency, vitamin C or ascorbic acid, which is very essential for the formation of collagen and intercellular material and bone and teeth. So a deficiency in the vitamin C will cause a decreased phagocytic function of neutrophils and macrophages, a decreased antibody responses, and a decreased cytotoxic T cell activity. Another systemic disease is osteoporosis, which is a disease characterized by low bone mass and deterioration of bone structure that causes bone fragility and increases the risk of fracture. Both osteoporosis and periodontal diseases are bone resorptive diseases, and osteoporosis is a risk factor for the progression of chronic periodontal disease. And there is a direct association between the periodontal disease as measured by loss of interproximal alveolar bone in postmenopausal women. A direct association has been reported. Coming to the next risk factor, which is the environmental and behavioral risk factor, that is smoking. Undoubtedly, one of the main and most prevalent risk factor of chronic periodontitis is smoking. So it has been shown to increase the severity and extent of periodontal diseases And when combined with plaque-induced chronic periodontitis, an increase in the rate of periodontal destruction is observed in patients who smoke and have chronic periodontitis. So as a result, the smokers with chronic periodontitis, they have more attachment loss, more bone loss, more furcation involvement, and deeper pockets. Coming to the behavioral factor, coming to the another environmental factor, that is the psychosocial stress. This will cause periodontal disease by altering the behavior, which can cause an increase in the smoking, or by decreasing the oral hygiene or poor compliance for the patient, or by overeating. These will causes ultimately leads to periodontal disease. Coming to the next risk factor, that is a genetic factor. The genetic basis for periodontal disease in recent studies that have demonstrated periodontal destruction among the family members and different generations within a family. And recent data indicates that a genetic variation or polymorphism in the genes encoding interleukin-1 alpha and interleukin-1 beta is associated with an increased susceptibility to more aggressive form of chronic periodontitis. Coming to the treatment of chronic periodontitis, this includes both non-surgical therapy and surgical therapy. The non-surgical therapy is the initial therapy, which includes scaling and root planing. Antimicrobial therapy is an adjunct to the routine periodontal therapy. Then oral hygiene instructions, reinforcement, re-evaluation of the plaque control methods, removal of all the factors which contribute to the plaque accumulation, like correction of ill-fitting appliances, correction of over-contoured crowns, overhanging restorations, etc. And then you need to reevaluate the patient and assess the need for surgical therapy. And coming to the surgical therapy, there are a variety of surgical treatment modalities that may be appropriate in managing the patient. That is, there are pocket elimination procedures, regenerative therapies, which include bone replacement grafts, guided tissue regenerations, combined regenerative techniques, and also resective therapies like flap, with or without osseous surgery, gingivectomy, etc. So in chronic periodontitis, after phase 1 therapy, that is scaling and root planing, antimicrobial therapy, etc., you need to reevaluate the patient. If there are about 1 to 2 sites per quadrant, or 4 to 5 sites in mouth with 5 to 6 mm of pocket depth and bleeding on probing, then again you can do a scaling and root planing along with the local drug delivery. If there is improvement, then you need to go with periodontal maintenance and reviews. And if there is no improvement, then the patient is shifted to the phase 2 therapy. And if there is more than 1 to 2 sites per quadrant, or more than 4 to 5 sites in mouth with 5 to 6 mm of periodontal pocket and bleeding on probing, then you can go for periodontal surgical therapy. And also during reevaluation, if there is 7 mm or greater or deeper pocket depth, then again periodontal surgical therapy. Coming to the prognosis of the disease, the slight to moderate periodontitis, the prognosis will be usually good, provided the inflammation can be controlled through good oral hygiene and removal of local plaque retentive factors. And in patients with more severe diseases, as evidenced by furcation involvement or increasing mobility, or in patients who are non-compliant with oral hygiene practices, then the prognosis may be downgraded from fair to poor. So to conclude, chronic periodontitis is an infectious inflammatory disease of the tooth supporting apparatus with progressive attachment loss and loss of alveolar bone. The effective management of periodontal disease in clinical practice presents with many challenges and cannot be completely cured, hence must be controlled in order to stabilize the progression of this destructive process in long term. Thank you.